Hello everyone and welcome back to Clinical Cousins YouTube channel. We're so excited to see you again. Today we're going to continue our discussion about the urine assembly line, as I like to call it. We're talking about the nephron. It's the functional unit of the kidney. So just for scale, we know that in each kidney there's about 1 million of these nephrons. So you have about 2 million nephrons to 2.4 million nephrons in total, and we're just going to talk about this little portion right here today. Okay, so we've talked about the PCT workers, the proximal convoluted tubule. We've talked about the loop of Henle workers and what they do. We talked about that important thick guy. And now we've talked about the early DCT as well. So now we're going to focus on the last part of the nephron, okay? We're talking about the late distal convoluted tubule and the collecting ducts. So these have the same types of cells, so that is why we collectively call them the aldosterone sensitive distal nephron, okay? It's a mouthful, but why do we call it this? Because it's sensitive to a hormone called aldosterone, okay? So very, very important. There's two types of workers that we're going to learn about today. One of them is called the principal cell, okay, and one of them is called the alpha intercalated cell. Sucky name, but we'll get used to it, okay? So principal cell guy, super, super simple, okay? Super important as well. Every single diuretic that you're going to give to your patients affects this in some way. So this guy has a sodium potassium ATPase on the blood side, just like every other cell in the body. So that's nothing new. We totally expect that. And on the urine side, and the urine tubule and the nephron, so simple. Okay, so we have a sodium channel and we have a potassium channel. We call this sodium channel the ENAC, okay, the epithelial sodium channel. So how did it get there in the first place? Well, we know that a little hormone called aldosterone came along and gave the principal cell instructions on how to build these sodium potassium channels, okay? So no aldosterone, none of these channels. So we have aldosterone, we're making more of these channels, okay? So the principal cell built these channels, stuck them in its pee hole, okay? No, I'm not talking about urethras. I'm talking about the urine side of the cell called the apical side of our cell, okay? So what happens? Sodium comes along in the tubule, okay, and our principal cells, remember, they're hungry for that sodium. Remember that the sodium potassium ATPase, it's pumping out sodium into the blood, so our cell is so hungry. The principal cell sees the sodium and it snatches up the sodium. Now, here's the catch. It actually snatches up so much positive sodium that it actually shoves that positive potassium out. Remember, there can't be too many positives in the same place. So our cell is hungry for sodium and it kicks out that potassium. So normally what happens in a principal cell? From a 10,000 foot view, we know that sodium and water are snatched up by the cell, put back in the blood, the reabsorbed where? Back into the blood, and potassium is kicked out. This is my favorite thing to teach about. I call this the sodium-potassium revolving door. As sodium comes in and water comes in, it kicks out that potassium. Okay, so let me blow your mind real quick. Remember those loop diuretics and thiazide diuretics that we talked about? Remember how they make you pee a lot of water and salt and potassium? Why is that? Well, remember, these diuretics that are working over here, they're sending massive amounts of sodium down this tubule. What happens when a ton of sodium reaches our principal cell who's hungry for sodium? That's right. A good chunk of all that sodium is going to come into the principal cell and is going to kick potassium out into the urine. So this is why the loop diuretics that work right here, like Lasix, furosemide, and the thiazide diuretics that work right here, hydrochlorothiazide, HCTZ, they're potassium wasting. Remember, they're sending a bunch of sodium that is kicked out, or that kicks out potassium through that sodium-potassium revolving door, right? We're sending sodium, sodium's going to come in, it's going to kick out that potassium. Okay, so let's pretend that we're in an unmedicated person. What happens if we gave this person a drug that blocks aldosterone? Okay, I want you to pause the video and then come back to see if you're right. If you are not a scaredy cat, I double dog dare you. Okay, so go ahead and pause the video. Okay, so you thought about it. If we block aldosterone, then the principal cell guy, he's not going to have those directions, right? He's not going to know what to do. Principal cell guy, he's a simple guy. He needs to be told what to do a lot of the time. So if we don't have that aldosterone, we're not going to have those sodium-potassium revolving doors. We're not going to have those sodium potassium ATPases. So the cell basically becomes a lot more ineffective. So what is different? Our cell, he's not hungry anymore. He's sitting there, he doesn't know what to do. So as sodium and potassium move through, as sodium moves through, this cell's not hungry anymore. So that means that sodium is going to be lost into the urine. Okay, remember, we have potassium inside of all of our cells. Okay, so this potassium, it doesn't have that revolving door. It's not being kicked out anymore. So that's why drugs like spironolactone and triamterene, they're called potassium sparing diuretics. So because if they block aldosterone, we're not going to have those revolving doors. That means potassium is going to be retained in our blood. Potassium is spared and remains in our blood. Okay, so important. Remember, potassium sparing diuretics, we're losing sodium, potassium is spared in the blood. Why? Because we don't have any of those sodium potassium revolving doors. Okay, so let's talk about the complicated, the sexy, the mysterious alpha intercalated cell. This is a mysterious guy. He does a pretty important job. He spits out hydrogen ions, okay, and he retains the potassium. It spits out the hydrogen, it sucks back in the potassium. This is important in acid-base regulation, and we'll talk about in a later video series when we go over acids and bases. Okay, but clinically, your patient is either a girl in her late teens, early 20s who's trying to clear up her acne, or it's going to be an old person with heart failure or hypertension. What are you going to tell them if you have to give them a drug that blocks aldosterone, like spironolactone or triamterene? Well, you're going to tell them the obvious stuff that you tell them with every diuretic. Don't stand up too fast. You're going to have to pee a little bit more. Also, you're going to need to lower your potassium intake. Okay, this is the key point. Are you just going to say that you need to lower your potassium intake because you don't have any sodium potassium revolving doors? No. Does everyone know what foods are high in potassium? No, and don't say just a banana, okay? You're going to tell them they actually need to limit their fruits and vegetables and consult a dietitian. They have to stay away from salt substitutes. They have to stay away from eating large amounts of potatoes and avocados. Why? Because those have a lot of potassium, and we know that they're already retaining a lot of potassium. You don't want them to eat a bunch of potassium. Why? Because they're going to retain it. What happens in extreme cases when we have too much potassium? It's called hyperkalemia. It's going to start to paralyze their heart and they can die. Okay, important, interesting, intriguing, cool science fun time. Okay, our posterior pituitary, it releases ADH, okay, antidiuretic hormone. The average Joe knows that it means that when we hold on, when we have ADH, we're going to hold on to more water, okay? We know that our blood's going to become a little bit more watery. But did you know that ADH actually acts on the aldosterone sensitive distal nephron to make aquaporin 2 channels? That is actually how we absorb that free water. ADH actually comes in through the blood. We insert these aquaporin 2 channels, and that is actually how we retain much more of this free water. That is how our kidneys help regulate our osmolality or osmolarity of our blood. So I hope that this video was very informative to you. It kind of ties everything together that we've learned about diuretics, and we get to talk about the cool principal cell, cool alpha intercalated cell. I hope that you guys have been enlightened by this video, and if you like it, please share it, pass it around so we can inform ourselves and become more informed practitioners in healthcare. As always, thank you so much for taking the time to learn with us today, and remember to like and subscribe for more content. Thank you.